couple questions of Director Roulard. Let me start with the fines, since that was referenced in the previous panel. And as Senator Bell talked about the fact that the general fund is certainly healthier than it has been in recent years, it triggered for me a question about the fines. A, are they enough? And B, what do you do with them once collected? Because as we talked about oversight and empowering you to hold plans accountable, that I know that I just don't know the line of, and is $4 million enough? You know, and what's next? So they have now complied, and I don't want to just pick on Kaiser, because Kaiser got excellence. There's a whole number of plans we haven't referenced here today who aren't doing as well as Kaiser. So this really is a global statement in terms of the fine process. Are you levying them? Do you think it's enough? Are they complying, and what happens to that money?
With regard to the fines are one of the enforcement mechanisms that we have to change plan behavior, which is ultimately what we're trying to do as part of our enforcement. And as to whether they're enough or not, you know, that's really a subjective question, because we want them to make timely access to care available to their members. They're going to have to spend a lot of money to do that.
And I wonder if the $4 million fine is easier to pay than having to invest what you have to invest.
Well, except that we're doing the follow-up surveys and continuing to conduct the investigation to see if they've corrected the deficiencies, and if they haven't, then there's going to be a next step that we will do. I'm not.
Which is what?
Well, we're not through the investigation yet, and you know, we could.
But the stick could get bigger.
Potentially, we could have a settlement agreement that it has something completely different, but it gets them closer to fixing the problem, which is what we want to do. I mean, frankly, I'm not sure you could fine any plan enough to correct the problem, because they need to take a lot of action within the plan to fix the problem. So I will say that it got their attention, and that they have been working really closely with us in the case of Kaiser. We have seen a lot of improvement in their ability to understand where the problems are. The problem still is that they're not taking timely action to fix them. But they are adding more providers. They are contracting with external organizations to try to make more providers available. So we know they're taking a lot of steps. Whether it's not adequate enough still remains to be seen, and we're still in the middle of that investigation.
And where are we with the other plans who aren't meeting the need? So this is done on a kind of a plan-by-plan basis based on the investigation, and then we go through that process? Yeah,
so through our survey process, we do look at timely access to care, you know, both on the physical health as well as the mental health side. And in none of the other surveys that we've done so far, and I can get you the specific information of which ones, we haven't seen the level of problems that we have with Kaiser. But I will also say that Kaiser probably has much better data than anybody else, and so to some extent they may be a victim of their own data, but the fact that they have it and they know that there are problems and they're not fixing them, that's a problem, and we want them to make it right. Your other question about where the money goes, the fines. So the first $1 million that the department collects in a year, and I think it's a calendar year, goes to the Steve Thompson Fund for loan repayment for providers who go work in underserved areas. That's the first $1 million. The rest of the money goes to subsidize premiums in the Mr. MIP program, the Managed Risk Medical Insurance Program, which now Department of Healthcare Services manages. So that's where the money goes now.
And as Mr. MIP phases out, we'll have an opportunity to
It would be up to the legislature to decide where the money would go if it doesn't go to Mr. MIP. And it is smaller, but there will always probably be a need for some level of service for people who can't get it elsewhere. But that's another conversation.
Yeah, I was about to say that's what I think, but that's not the signal we've gotten from the administration, but okay. As I listen to you drill down and talk about kind of the three areas, the financial health, quantitative and non-quantitative treatment limits, it occurred to me that perhaps we, the collective we, make a mistake and when we think about network adequacy, that we equate that with provider appropriateness. and we shouldn't. They're two different things. And so from that aha moment, I moved to, I really wonder if we're measuring the right things. That, as you are doing, because of the federal regulations, because of the legislature's laws that we pass on top of law that you're trying to catch up with, and the SB 964 implementation is going to be delayed because you've got to get all this stuff straight. None of that appears to have impact on the two, albeit two, case studies we heard at the top of this hearing. And so from your perspective as director of the department, are we indeed measuring the right things?
Well, as to the appropriateness of the providers and whether they are qualified to serve the range of disorders or ages or whatever the situation may be, we're really not in a position to evaluate that because we are not clinicians and we don't know that information. But if the legislature wants to consider something like that, then that's certainly your right and prerogative. So,
Well, don't suggest another bill for us to write.
I'm not suggesting anything. I'm just saying you can do it if you want.
But your comment is very telling in terms of that's not in your purview.
Right, it's not.
And, you know, and so then the question is, then whose purview is it? In terms of their license, I get that. But how does that then equate to making sure that I'm in a plan that has a provider that meets my needs? You see what I'm saying? It's the licensing issue is up here, but as we dig deeper to really talk about some of the issues we've heard today about access and adequacy, I don't know that there's a connect.
And I think it goes to standard of care. So if a patient comes in, then it's up to the provider network to determine where that patient goes to for that appropriate amount of care, whether it's somebody's going through a divorce, they're depressed, as opposed to if somebody's suicidal. Then if they go to that appropriate area of care and that particular provider is, you know, not doing his or her, you know, standard of care to provide for that, then they get disciplined by their particular licensing boards. So,
well, but I guess for me that there's a lot of room in between there, because it's not about it's not a standard of care issue from the licensing perspective. It's I am in crisis, and this provider is not meeting my need. Ms. Reagan was in crisis, and that medication was not meeting her need. You see what I'm saying? So it's not a blatant deficit on behalf. This might be a perfectly good psychiatrist for somebody else. They are not meeting my need, and I am in crisis. And so that's where I'm saying this kind of disconnect between, when we talk about adequacy, we want to make sure that the network has enough people to fill these slots.
So, you know, our department's help center can help folks who are in that situation try to find a provider that is suitable for them, because the plans are required to have providers to meet the needs of their enrollees. And if the provider network can't meet the needs of the enrollees, then the plan is obligated to find a provider outside the network if possible. But we have, most patients aren't in a position to be able to advocate that for themselves, especially if they're in crisis, which is why I would like, again, to encourage folks to call the help center, because we do have a mechanism for dealing with urgent problems. We have nurses who are clinicians who can help with that, and then we can collect the data to see what the scope of the problems are and then work to address them on a more systemic basis.
And so finally, getting back to the parity issue, we spent a lot of time talking about making sure, particularly as we transition from fee-for-service to managed care, making sure that people had access to the right provider, their historic provider, and have created lots of opportunities for people to be able to opt out on the health side. And is that the case as we talk about parity on the mental health side? Are plans open to allowing people to opt out or work, as you suggest, to find them a provider that's appropriate?
Are they open to it? Well, they're required to do it if there's not a provider that can meet that person's needs in the network. And that would be the same if it was a specialty for a specialist for a certain child who has a rare disorder. The provider may not be in the network. They have to make that available outside the network. So.
Thank you.
Okay.
Senator Bell?
Yeah, just as a former chair of board that governed a public hospital, I could say that unless we intervene to prevent continuous deterioration of somebody's acuity and mental health, they'll end up in the emergency rooms, and they'll drop out of insurance and into the public realm, Medi-Cal realm or an uncompensated realm of healthcare that will be handled by emergency rooms in public health system, so a public hospital system, so and nonprofit hospitals. So I think for me, measuring your success should include some kind of independent survey by UCLA or the Public Health Survey or whatever to see, to kind of look at whether or not there's an adequate mental health services provided to consumers. So you have kind of a benchmark that you can measure your success or failure to. Does it go up? Do people feel more comfortable? Do they feel their access to services better? Are they getting timely service? Those kinds of things should not be based on how well you handle complaints or consumer complaints, because as we know, people with mental health often do not even complain. In some cases, don't even think they have a mental health problem as well. So there's sort of a need for some multiple layers of measurement of how you view your success. And I think that's something I would hope that you would agree with in terms of evaluation. So the other thing is, do you have enough staff to actually review the plans in depth? Is this a level, an inadequate level? As you know, when we presented the budget request with the Senate Mental Health Select Committee members during the budget process, was in 2014. 14-15. We asked that a certain level be funded. It was a lot of back and forth. People didn't like the fact that we made that request, but we ended up getting a compromise at the hearing. People said, okay, that's a good compromise, we'll agree to it. And then lo and behold, half the money got blue penciled by the governor after we had an agreement. So I kind of feel myself that the original amount was the correct amount of money, and it should be double. I believe, I still do, that it should be double the amount of money be put into enforcement, so you can go deeper at a deeper level of enforcement and review of the plans, and do enforcement so that you don't have so many cases slipping through the cracks. And I wanted to ask you at this point, is there a way you can accommodate the request to do a review of cases that slip through the cracks, or maybe some cases that can be brought to your department's attention in terms of helping you evaluate your success in terms of parity and the enforcement, such as the Reagan and Winsell cases? Is that taking some of those cases and then just kind of dissecting them and breaking them down to see what went right, what went wrong? Is that something that would be helpful in terms of reviewing and using that to correct processes that you need to add to make the review of these health plans more effective?
Okay. So I'll start with the end. You had a lot of stuff in there. I'll see if I can respond to it.
I have a lot of stuff for you.
With regard to the cases, I don't know if we've heard about that. Okay, so I don't know if the Reagan family has contacted our help center about that, but if they do and they want to, we could certainly look into that. So that's the way that we deal with the individual cases, is through our help center and trying to assist people and resolve those problems. So again, I would just encourage folks who have issues to contact us.
Well, my request was to use that case as a way of doing some kind of a post-evaluation of how the health plan treated.
Right.
that.
When these situations come to our attention through the media or whatever, and we do have an active investigation going on with Kaiser, we do ask them about that. So I'll check with our Office of Enforcement and see how much that particular family situation, how we're using that in our enforcement activities. With regard to the budget and the positions, we did get 5 positions in 2014-15, which have been filled. And then for the 2015-16 budget, we have 11 more positions, including 2 in the Office of Enforcement. The rest will be in Help Center and Plan Surveys, and we are in the process of filling those. We've got some of them filled, but not all of them yet. So at this point, Senator, I appreciate your support for wanting to get us more resources. I think we're good for now. We also have quite a bit of funding for our consultants who are our clinical experts that help us with those surveys. So I think we're good. Thank you for your support.
I had one more question, Mr. Chairman. We talked about, maybe the mental health services in some plans, large plans, and others may be good in some areas, but a little not so good in terms of access in other areas. When you review a plan, do you have what they call cross-tabulations in terms of regional differences, performances in the plan? Like maybe for example, it might be better in the Bay Area or Sacramento than in, say, Santa Rosa, for example, or it might be better in Los Angeles than Sacramento.
Right.
Do you have a way of evaluating the plans on those in terms of regional disparities, if you want to say, and then the other types of disparities, obviously, are the children versus adults, gender, ethnic, socioeconomic kind of area, like if areas of predominant low-income residents have disparities as
So in terms,
recently seen in the news publicity recently.
So in terms of the provider networks, we do look at the, as I said, the availability of providers in a particular area and the number of enrollees that a plan has in that area to see if the ratio is appropriate, as well as the various types of providers that are available in that area. There may be some areas of the state, and we know this is true in rural areas, where certain specialists are not available there. So plans still have to make arrangements to have those services available to people, even if they have to travel outside of their service area. So with regard to kind of the issues that Senator Mitchell raised about the types of providers and the types of people they can see, that is really not part of our review at this point. We want to make sure that they have psychiatrists and child psychiatrists and psychologists and all of those types of providers. But as to whether those folks can serve by people with bipolar disorder or schizophrenia or substance abuse, we don't have that expertise or information specifically.
Now, the Covered California people have, they do reviews also of health plans and so forth. Do they or do they collaborate with you in terms of reviewing the adequacy of the health plans, especially in the area of mental health? Is that something that's done? And how is that done in terms of both, I guess both of you? I don't want to not have you respond as well, but I think the Covered California is in my opinion, has been very successful. We've done a pretty good job in reaching out and getting people to sign up, but there is a lot of people there, and therefore we're concerned about making sure everything is adequate in all areas of California. So is there a collaboration with you on the enforcement of mental health parity with them?
Absolutely. We collaborate with the Covered California. We do, as CDI does the review of their networks to determine they're adequate, even though there may be smaller networks. We want to make sure that they have adequate numbers of providers to serve the enrollees. So we do work very closely with them around that.
I would say the same thing. And the additional piece I would add, in addition to them, asking us to confirm that the plan meets the network adequacy standards in statute and regulations, there's also communication about the inaccuracy of provider directories and trying to get those things resolved.
So I have a couple comments, and from there may come some questions. So first of all, let me thank both the regulators here, whether, obviously the Department of Managed Healthcare and Department of Insurance. It's obviously it's your responsibility to make sure that the plans have adequate networks, and these networks are the responsibility of the plans to provide, whether it's access, parity, timeliness, distance, on and on and on. And understanding that a plan can do several things. A plan could either contract directly with a provider, a plan could contract with a plan that provides these services, but it is ultimately that plan's responsibility to provide these services, whether it's minimal to extreme cases of suicide, et cetera. And obviously it's your responsibility as regulators to make sure that they do. The hammer or the stick is the fine, and if they don't, then it ramps up. But when we look at, for example, like the state mental health parity law, which was dealing with severe mental illness, and by the way, I don't know if she's still here, I saw her come in. Former Assemblymember Helen Thompson's here, so I'd like to recognize her for that as well. She's here, she's here. I thought I saw her come in. And then when you look at the essential health benefits, which expands that to substance abuse and expanding to more mental illness, here's where my concern is. Not that you're not doing your job, and the plans want to provide this care, they want to get contracts, they want to see patients, and I think it'll be answered perhaps in the next panel is, do we have enough providers to provide these services to all the patients that are coming into the system? And the reason why I ask this is because we definitely have that problem in primary care. We have that problem in Medi-Cal. We have it in distribution. We have it in access. We have it in communities of color. We have it in rural communities, et cetera. So if we don't have enough providers, how are we going to solve that? And for me, that's the biggest problem. And I know Kaiser, as you mentioned, is starting to fill those positions, but I can't imagine those providers just showed up. Are they taking them from somewhere else? And, is the workforce kind of shifting? So I guess my question for you is, how do you determine the network adequacy of a plan, and if they don't meet it, and then let's say do you do it for all the plans equally, and do you feel there's enough providers out there to fill the need for all these benefits that we're going to have to provide for these consumers? I mean, what is your thought about true network adequacy here in the state of California?
So we are limited by what's in the law in terms of what our authority is to determine network adequacy, and we do follow that. And so I can say with certainty that all of the networks that we have approved are adequate based on the law. What you're asking me is like writ large in the grand scheme of things, do we have enough providers? And I don't know the answer to that question. I have no way of knowing, but one of the ways in which we try to assess adequacy, as I said, is around timely access to care. If people can get in time, in a timely way to see a provider, whether it's a primary care or a specialist or a mental health provider, then that's what we're trying to achieve, timely access to care, whether they have one provider or 100 providers. So that's how we try to evaluate whether or not the networks are adequate. And so this is still, timely access compliance is still a work in progress. As you know from your bill, we've got 5 years to come up with a methodology that everybody will adhere to. And so that's what we're working towards. And I hope, as long as that we will finish that while I'm still in this job.
So from the mental health perspective, with having enough, all the plans meeting their network adequacy, and I believe you made a comment earlier about the help center at the Department of Managed Healthcare doesn't get very many calls on mental health. And I'm assuming that you have the same response as well to getting not as many requests or concerns with regard to mental health as far as the complaints? Is that correct?
That is correct. In terms of the overall complaints that the department receives, for those that are not IMR situations, the department is 3 to 4% of the health complaints we get are mental health. A higher percentage of those that are appropriate to go through the IMR process are mental health related, though.
Okay. All right. Thank you. And then with regard to, I think somebody brought up earlier about that if the patients can't be seen within a particular entity, they need to go out of network or go to maybe private pay. Do you have any evidence that's showing that patients are going to, or when you ask surveys, if they're having to go outside a network and paying out of pocket for any of these covered services at all?
Actually, I'm going to ask Casey. I think you're the person that can talk to speak to this. Casey Cameron, who's one of our attorneys in licensing that works on networks. And how do we look at out-of-network care?
Hi, thank you. So to answer your question, we as a department take the position with plans that if they cannot offer adequate access to a basic health care service as defined under the Act within appropriate network adequacy provisions, then we will request that they arrange for an out-of-network provider for the enrollee at in-network cost share. As a network review team, if we find that a plan has a particular problem area, and this happens frequently in rural areas where there are a very limited number of providers and many of those providers are unwilling to contract with health plans, we will ask them when we approve their network to agree to a condition that they will provide that particular specialty type or physician type to an enrollee at the in-network cost share and arrange for the out-of-network care for that patient. So we, as a network team, when we do a network review, try to ensure that every single specialty is accounted for. If it's not available in the network for a good reason, then we want to make sure the plan is making arrangements for out-of-network care. That happens, like I said, frequently with providers who are unwilling to enter into arrangements with health plans. With regard to tracking out-of-network referrals, that is an item that we will often include as a condition in an approval. So if we believe that there's going to be a need for a patient to go out of network with some level of frequency, then as a condition on that approval, we will ask the plan to report back to us on the number of referrals that go out of network. We also engage in a regular review of Medi-Cal networks as part of an interagency agreement with the Department of Healthcare Services. And as part of that agreement, we receive on a quarterly basis from every Medi-Cal plan a detailed list of every provider type that a patient was referred out of network for and the number of referrals that were made. Where we see a significant number of out-of-network referrals, usually around 3 or more, we'll do further follow-up with the plan regarding whether or not the providers that are reported as being available in that network are accepting the patient, what they're doing about improving their network to arrange for those services, et cetera. So.
Okay, thank you. So I would like to just thank both of you and all of you for being here for this afternoon's presentation, and we're going to now move on to, see no more other questions, we're going to now move on to item number 4, mental health provider assessment. We have Linda Onstad Atkins, Acting Director, Healthcare Workforce Development Division. We have Eric Resluck, Assistant Director, Legislative and Public Affairs Officer of State Health Planning and Development. If we can have both of you come up.